So like what we are doing, like what we did in our WhatsApp group, you asked that we go over the questions the medical council has revealed. And that is exactly what we're going to do today. I'm taking you through a very important one, and then we will do a deep dive into the concept. So let's get going. So those who don't have any idea about how to get access to the free questions, I'm sharing the link right now in the comment section. Okay, I'm sharing the link right now in the comment section. Please take advantage of that and use it. You'll be able to practice all the free questions the medical council has for you. So please, if you've not tried it, use it. And we are using those questions to be a basis for all the lessons. And so far, if you want to watch the others, just go to the MedCognito YouTube page, okay? And then go to the live sessions. You'll see that everything is there for you. So you can use that to learn. And today you will understand how we do it at MedCognito. So please, if you are ready to rock and roll, just type ready. Just type ready. Let's go. Ready, let's go. It's been some time. I did this. So just type ready. I'm ready, Dr. Bruni. I'm ready. Let's go. I'm ready, Dr. Bruni. I am ready. Good. Dr. Rockefeller says he's ready. So let's take the question. It says that you have a 77-year-old man who presents to your clinic because of urinary incontinence for the past 2 months. He says that his bladder always feels full and he frequently loses bladder control during the day. For the past year, he's had to urinate every 2 to 3 hours and has had nocturia. Then it says, which of the following is the most likely diagnosis? So if you want to see the way the medical council sets questions, this is how they set their questions, right? It's a reflection of what is happening in the free resource. That is why I want you to use this very, very well. Number 1, interstitial cystitis. Number 2, prostate cancer. Number 3, neurogenic bladder. Number 4, chronic cystitis. And number 5, overflow incontinence. Doctors, get the answers going because we are going to do a deep, lengthy dive into the concepts revealed in this particular question. So please get your answers going. Okay, so I see someone going for C, which is neurogenic bladder. I also see someone going for E, which is overflow incontinence. And we're going to use this class to really break everything down for you to appreciate why we went for a particular answer and why we went for a different answer. Okay, so Dr. Ruth Ann says E, Dr. Rockefeller says E, Dr. Kanika Sharma says E. So who went for C? Because the C seems to be becoming problematic. The one who went for C seems to be getting into a bit of trouble. Okay, so let's get the points here. Okay, so it looks like now everybody's going for E, overflow incontinence. Okay, good. So the answer is E. And it's not just about, saying, the answer is E, therefore I'm okay. No. Today, I want us to do as we've done in the past. And the principles in this particular question, we're going to build on those principles. So today, we are going to learn 5 topics in one class, right? So the question says that there are so many clues this question gives. The first thing is that this is a 77-year-old man. That's number 1. Number 2, he presents to your clinic because of urinary incontinence. So we know that this patient has urinary incontinence. That's what the question is already telling us. And we know that there are various kinds of urinary incontinence: urge incontinence, stress incontinence, overflow incontinence, all those things. Now, he says that his bladder always feels full. Okay, so it looks like this is something which is there all the time. and he frequently loses bladder control during the day and night. For the past year, he's had to urinate every 2 to 3 hours. My goodness, that's a very uncomfortable situation to be in. And has had nocturia as well. Which one of the following is the most likely diagnosis? And the options were interstitial cystitis, prostate cancer, neurogenic bladder, chronic cystitis, and overflow incontinence. And a lot of doctors seem to go with overflow incontinence, right? So if I should show you the answers, apart from Dr. Salihu Kwara, who went for C, Dr. Gael went for E, Dr. Kanina Sharma went for E, Dr. Rehab went for E. This doctor is laughing. And then Dr. Dushan went for E as well. Now, I said that this question has left a lot of clues. Let's look at the rationale the Medical Council gave, then we will get into the deep dive. Now, aside that, look at the reference the Medical Council gave. StatPels. StatPels. So I'm going to just link that as well in the comment section, okay? So StatPels Publishing. That's what they urine incontinence. Okay, good. So doctors, this is why for me, you realize that your MCCQE1 questions are set from research articles and standard text, right? So that's why they are using up to date. And then so if you want to see where they got this particular concept from, it's from this article, StatPels. So National Center for Biotechnology Information, National Library of Medicine, right? They got it from here. They got it from here. I'm going to send the link to you. The reason why I'm drawing your attention to this is, everyone talks, Torontonos. Yes, very important book. However, always remember that the Medical Council does its best to also source questions from these resources. And that is why I always say that always use the objectives and always use the standard text that they want you to use. All right? Always use the objectives and always use the standard text that they want you to use. Okay, so I'm coming back to it. So I've showed you the exact article they got a question from. Now, the described symptoms are characteristic of overflow incontinence, and hang in there because I'm going to go into details and do a lot of deep teaching today, which occurs when the bladder is unable to empty properly, leading to frequent leakage as the bladder overfills. Now, this condition is often due to bladder outlet obstruction. So think about it. This is an older gentleman, and we know that at the tip of the bladder sits the prostate gland, right? Commonly caused by benign prostatic hyperplasia in elderly men. So this lesson also teaches me something that, look, the commonest cause of bladder outlet obstruction in elderly men is, please, I need you to write this down, benign prostatic hyperplasia. Benign prostatic hyperplasia. I need you to write it down because we'll be dropping so many pearls as this class goes on. We are not just solving a question. We are using the questions to dig deep to know exactly what the Medical Council wants us to know. So benign prostatic hyperplasia is the commonest cause of bladder outlet obstruction in elderly gentlemen. Okay, now interstitial cystitis, which is a chronic condition causing bladder pressure and pain, does not typically present with overflow symptoms or a constant feeling of fullness. So you realize that the clue the question is giving you is that you need to know how bladder outlet obstruction presents, how interstitial cystitis presents. And the clue here is that if you have a patient with interstitial cystitis in your board exam, the patient will present with pain. Meanwhile, this question stem did not talk about that. Okay, next one. Prostate cancer was one of the answer options. It might cause urinary symptoms, but is less likely to present with specific pattern of overflow incontinence without other systemic signs. So what this question is basically saying, or what this rationale is basically saying, is that by the time a patient with prostate cancer starts exhibiting symptoms of bladder outlet obstruction or overflow incontinence, it means that bladder cancer has really advanced, right? Now, neurogenic bladder. Neurogenic bladder resulting from nerve damage could cause similar symptoms, but would likely be accompanied by neurologic signs and symptoms. So how do you pick up neurologic bladder in your board exam? Always look out for the fact that the question will add some neurologic symptoms of a sort. Okay, now, chronic cystitis. Usually you realize that if there's chronic cystitis, the patient will say that this has been going on for a long time, and the question stem will also give you some clues. One of those clues is that maybe the patient has pyuria all the time. Whenever they do the urinalysis, there's elevated white cell count, there's nitrite, there may be blood. That should point you to chronic cystitis. So my point is basic, that look, the medical council and the MCCQE1 and all other board exams, so whether it's the USMLE, the AFM, the AMC, which is written by Australia, the PLAB, which is written by the UK, or even the Saudi Arabia board exams and all those things, the MCCQE1 and all other board exams are about picking up specific clues about that specific patient in that specific question, not only memorizing facts. And that is why I always want you to make sure that you put the patient in context. Okay? Put the patient in context. So, for me, in that particular question, there were 6 clues, but I'll just focus on 5 of them. There were 6 clues, but I'll just focus on 5. The first clue is a 77-year-old man. Today, I want to take time and help us to come to appreciate how we need to think through these questions, right? How we need to think through these questions. So the first clue is that this is a 77-year-old man. The next clue is that the patient has had urine incontinence for the past 2 months. The next clue is that the bladder always feels full. And all these have been provided by the question. The next clue is that the patient frequently loses bladder control during the day and the night. The next clue is that this patient urinates every 2 to 3 hours. And the last clue is the nocturia. And the nocturia is already covered in the urinates frequently during day and night. That's why I dropped that nocturia as a clue. So now let's take time and get into it. The principle with the QE1 is that always use the clues to solve the question, not just rote memorization. Always use the clues which you are given to solve the question. Doctors, before I move on, I want to make sure, are you following me? If you are following me, just type yes, Dr. Bruni, type yes, because we are going to use this question to now do a deep dive into all the components, so that now when you see a neurogenic bladder, you will remember. When you see chronic cystitis, you will remember. When you see overflow incontinence, you remember. Okay, good. So please, let me know. If you are picking up what I'm laying down, if you are picking up what I'm laying down, if you are picking up what I'm laying down, if you are picking up what I'm laying down, type yes in the comment section. Okay, good. So now, 77-year-old man. This what does this tell you? 77-year-old man. This tells you that this is a prostate pathology. Think about it. Most likely a prostate pathology. Okay? Most likely a prostate pathology. Because it's a man, and it's males who have prostate issues. So this is not pointing to a female. So the possibility of a prostate pathology in a female is 0, right? So 77-year-old man strongly points toward prostate pathology. And the most common urinary cause in elderly men is benign prostatic hyperplasia. I've already told you this. Number 2, what is the diagnostic impact on this patient? This patient has been having this for some time. And you realize that it's a chronic bladder outlet obstruction the patient has. And it's usually a precursor to overflow incontinence. So this makes interstitial cystitis and chronic cystitis less likely. So it's like in a question we are solving a puzzle, right? And it does not immediately point to neurogenic bladder. And one clue you should note in a question stem with neurogenic bladder is that the patient will have some neurologic symptoms. Or maybe you'll be told that the patient might have had a stroke or long-standing poorly controlled diabetes, and therefore the bladder detrusor muscles are not responding to the innervation in the bladder. Number two, the second clue is that this patient's urinary incontinence has been there for 2 months. What does this tell you? It tells you that the incontinence is new. It is not a lifelong thing, right? It is new. It is not a lifelong thing. And it also suggests that there's decompensation of a chronic process, not a primary bladder disorder. So it looks like this has been going on for a long time, and now the body is not able to handle it anymore. And for the past 2 months, it looks like an acute on chronic thing. Doctors, please, I have a question. Am I making sense? So it looks like this has been going on for some time, and then for the past 2 months, the body just cannot tolerate it, and therefore we have an acute on chronic thing, which is now building up. Okay? Now, overflow incontinence you realize that it appears late after there's been prolonged period of obstruction. So if you should take your time and dig into the history of this patient, you realize that the patient will tell you that, oh, doctor, I've been having hesitancy for some time. I've been having low urine stream for some time. Whenever I go to the washroom, it feels like I have been unable to empty my bladder. I've been having a feeling of incomplete bladder emptying for some time. But then it looks like in these past 2 months, I've had to go to the washroom every 2 hours or 3 hours. And when I go, it does not feel like I've been able to empty my bladder. So I'm always having to, go to the washroom. If I'm driving, I always have to be careful and make sure that I park by the roadside somewhere, go into the bush and pee every 2 hours. And my wife has even been complaining about it. And doctor, I always feel that there's heaviness in my bladder region. So you realize that if it's a McCoskey case you are dealing with, this patient will tell you that this is what has been preceding. Then in the last 2 months, boom, the symptoms just started getting worse. It doesn't mean that everything started 2 months ago. It means that it's been boiling for some time, right? And then it's like a patient who has been having angina, and then boom, a big myocardial infarction happens. That is what is going on here. Now, but what about chronic cystitis? In chronic cystitis, you realize that the patient would have presented earlier, and the patient would have presented with pain and signs of infection like fever. And if the infection is not dealt with, the patient will complain of flank pain. Okay, what about neurologic bladder? Neurologic bladder usually would follow a neurologic event or a neurologic disease. And the question stem will tell you. But this time, you were not told anything. Doctors, again, I want to pause here. We are trying to break the question down so we'll be able to make it up, whenever we are in a board exam. This second clue, we've dealt with the age of the patient, the fact that the patient is a male. We've dealt with the fact that this has been going on for 2 months. Are we picking up the pieces we are putting together? Please, doctors, are we picking up the pieces? Now let's go to the third clue. The third clue is that the bladder always feels full. And for me, this is the most important clue in the whole question. So if the bladder always feels full, it indicates that there is urine retention. And that means that the bladder is not emptying properly. Doc, look, this is how you think in the board exam. Okay? The bladder is always full. So if the bladder is always full and the guy is going to the washroom every 2 to 3 hours, why can't he empty his bladder? Because there's something blocking the mouth of the bladder, and that's the prostate, right? Now, this is how overflow incontinence presents. So overflow, why? So the bladder is full, but the guy is peeing out what is spilling over. So even when he pees out, there's always something left in there. And that is why there's always bladder over distension. So if you do a physical exam, you realize that this guy's hypogastric region is a bit bulged, right? Because there's still urine there. Now, in interstitial cystitis, no, the bladder will not be full. Rather, interstitial cystitis causes pain, and the patient feels relieved after he pees. But in this particular patient, when he's done peeing, he still feels that there is some urine left in there. What about chronic cystitis? We learned that chronic cystitis would be ongoing for a very long time. There will be urgency. There will be dysuria, not retention. Doctors, are we picking it up? 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 Now, what about prostate cancer? Prostate cancer alone does not cause constantly full bladder on its own, unless it is so bad, like it's become so bad, then in the later stages you can see that. And then neurologic bladder or neurogenic bladder, I will not go for that again because this patient does not have any neurologic clues. Next clue. He frequently loses bladder control during the day and the night. What does this tell me? This tells me that the leakage of urine is constant. Every 2 hours, this guy has to go. It is not situational. And it happens regardless of this gentleman's activity. Right? Whether he's active or he's asleep, it's happening. Why? Because the bladder is always full. So if you have a patient who is having continuous leakage, think about the fact that the cup is already full. Okay? The cup is already full. And because there is more urine which is filling up, that is why it is overflowing. And this guy will tell you that, Dr. Brony, look, I'm not having refreshing sleep. I sleep, I wake up, and it's as if I need 3 more hours of sleep. Why? Because he's been waking up throughout the night. Interstitial cystitis will cause urgency, not constant leakage. Chronic cystitis. Now, the difference with chronic cystitis and interstitial cystitis is that even in chronic cystitis, even after the patient has peed, there will be pain. In interstitial cystitis, after the patient pees, the pain goes down. Boom. Doctors, please, I want us to pick it up. So, overflow incontinence. This guy goes, he has to pee a lot of the time. He has urgency. Chronic cystitis, this guy has to pee all the time. Interstitial cystitis, this guy has to pee all the time. Now, what's the difference between chronic cystitis, interstitial cystitis, and overflow incontinence? In overflow incontinence, typically does not present with pain. It presents with a feeling of fullness. Now, the pain comes in with chronic cystitis and interstitial cystitis. But the beautiful thing is that with interstitial cystitis, when the patient pees, the pain goes down. In chronic cystitis, even after the patient has peed, there will still be pain. Now, and that is what tells you the difference between one is an infection, that is the chronic cystitis, and the other one is not an infection. The other beautiful thing about chronic cystitis and interstitial cystitis is that in interstitial cystitis, the patient will constantly present with urinary symptoms, but whenever you do your lab work, the urine is sterile. There is no increased nitrites, there's no increased leukocytes, there is no blood most of the time. But with chronic cystitis, whenever you do your urinalysis, there's pyuria, there's increased white cell count. There's at times blood, there's nitrites. That tells you. Okay, good. Let's go to the next clue. He urinates every 2 to 3 hours. What does this tell you? It means that frequent voiding of small volumes. He's not able to pee, large volumes. It's chop, 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 small, right? So for me, if somebody is having to pee a lot, but then has to go again and again and again and again, it tells me that, look, the storage place, which is the bladder, is not emptied completely. So this is a typical hallmark of chronic retention. And the bladder never, ever fully empties. And this guy has to make multiple attempts in order to empty the bladder. Now, what about interstitial cystitis? We already said interstitial cystitis, there will be pain relief after voiding. But in chronic bladder obstruction, which is leading to overflow incontinence, the patient will always say that, doctor, there's still more urine left. In chronic cystitis, there is urea. In prostate cancer, it being alone will not cause these symptoms unless it is advanced. Now, so why each of the options is wrong, like the other options apart from the overflow incontinence? With interstitial cystitis, again, I'm trying to drum it into your mind so that these 5 diagnoses will never beat you, because it's a very important MCC objective. And why do I say that? Doctors, you see why I'm always talking about the fact that we need to make sure that we focus on the objectives. So let me remove this and then let me add this to the thing. You will ask yourself, okay, Dr. Bruni, let me share this screen with you so you know why I'm always focusing on this thing. Why am I always focusing on this thing? Please look at this. Look at the objective very well. Why did the Medical Council drop this free question in their 55 questions? There's a whole objective on incontinence. And look at what they state, because before we go into why the rest of the answers were wrong. The rationale is that incontinence has increased in frequency as our population ages. That is why they dropped that question of a 70-something-year-old gentleman, right? Incontinence has a detrimental effect on quality of life and impact on physical and psychological health. That's why I said that it will even have an effect on the guy's sleep. Now, what are the causal conditions of incontinence? Transient causes like polyuria, impaired ability or willingness to reach the toilet, medications and alcohol. And then neurological. That is why in your question stem, the answers, they dropped the issue of neurogenic bladder as well. And then there can also be anatomic issues like stress incontinence, urge incontinence, and overflow incontinence. Doctors, please, this is what I'm talking about. Use the objectives to study. Because if you use the objectives to study, you realize that the medical counselor has told you exactly what they are going to examine you on. So look at the objective. Given a patient with urinary incontinence, the candidate will diagnose the cause, the severity, and the complications. So that is why you must be able to differentiate between overflow incontinence, urge incontinence, interstitial cystitis, chronic cystitis, urinary symptoms caused by prostate cancer, and will initiate an appropriate management plan, in particular, addressing the 2 most common causes, which are stress incontinence and urgency. Then the enabling objectives. Given a patient with urinary incontinence, the candidate will list and interpret critical clinical findings, including an appropriate history. So this question I dropped is basically testing your knowledge on, look, Dr. Rockefeller, can you use history alone to differentiate between prostate cancer, chronic cystitis, interstitial cystitis, urge incontinence, and overflow incontinence from history alone? Then they went on, and physical exam, including pelvic, rectal, and neurologic exam. So for example, if you have somebody with a neurogenic bladder, what physical exam features point to that? If you have somebody with prostate cancer, how does prostate cancer feel on physical exam? How does that differ from benign prostatic hyperplasia on physical exam. Okay, and then list and interpret critical laboratory investigations, including urinalysis and culture. And we've learned today in interstitial cystitis, urinalysis will be clear, but the patient will have symptoms. Meanwhile, in chronic cystitis, you realize that the patient, whenever you do a urinalysis, there's an abnormality in there. And then counseling of patients regarding therapeutic and surgical options like anticholinergic medication for urge incontinence and psychosocial impact, and then making an appropriate referral. Doctors, you see what is happening? So the medical council does not just drop questions in your MCCQE1 exam. No. Any question they will drop, I will tell you for a fact, it is in the objectives. And I'm happy that we've seen it play out clearly. So why were each of the options wrong? Based on the clues, interstitial cystitis would have bladder pain, which is relieved by voiding. Prostate cancer is often asymptomatic early, and there's fullness and overflow, which will occur late. Neurogenic bladder requires neurologic disease or injury. So maybe the patient might have fallen on stairs, and then if it's a neurogenic bladder issue, you'll be given that clue. And chronic cystitis, there'll be dysuria, there'll be urgency, there'll be signs of infection, not retention. So let's do some deep dive into urine incontinence concepts. So this 77-year-old man has classic features of chronic urinary retention leading to overflow incontinence. The bladder is always full, which suggests that there's incomplete emptying. Frequent loss of bladder control day and night. That means there's continuous dribbling and overflow, right? And then long-standing lower urinary tract symptoms. If he's urinating every 2 to 3 hours, if there's been nocturia for a year, this is typical of bladder outlet obstruction. And we've learned this. I'm just trying to re-emphasize it. And over time, the bladder becomes overdistended and cannot empty properly, which leads to the leakage, the overflow leakage. So doctors, now that we've done all this, let's remember some facts. Interstitial cystitis, let's learn it quickly. There's bladder pain. There's urgency. There's frequency of urination. What will make interstitial cystitis less likely in your board exam? It does not present with persistently full bladder. So if you have a patient who you are told that the bladder is always full, that is not interstitial cystitis. Now, this doctor is asking this very important question. Doctors, how do I answer this doctor? He says, will the video stay on YouTube? Doc, do you want me to take the video off YouTube? You want me to take it off? No, I will not take it off. I'll keep it there for you, please. I'm doing this for you. It will stay on YouTube. It will stay. It will stay on YouTube. It's not going anywhere. Okay? Good. So, interstitial cystitis. The patient will present with bladder pain, urgency of urination, frequency of urination, and interstitial cystitis in your board exam. Always watch out. The patient will you'll never be told that the patient has a full bladder. No. Because as soon as the patient feels like peeing, boom, he has to go to pee and it will come out. Okay, good. What about prostate cancer? In your board exam, you realize that patients with prostate cancer will be asymptomatic in the early stages of prostate cancer. You'll be asymptomatic, nothing. And usually they will have storage and voiding problems later on, especially if there is spread. And they may develop, erectile dysfunction if the prostate cancer may be spread to the back and the rest, right? Okay, good. Now, neurogenic bladder. Look out for features of neurologic condition as part of the clinical presentation. And what are the common features I want you to look out for? If you are told that the patient had a stroke. Number 2, if you are told that the patient has spinal cord disease, or if the patient has poorly controlled diabetes, which has led to neuropathy. Boom. That tells you that this is a case of neurogenic bladder. Doctors, can I move on? What about chronic cystitis? Chronic cystitis will cause dysuria, urgency, and frequency of micturition. There will be no chronic retention with dribbling. Why? Because the patient has a bladder infection already. So the little urine which comes in, boom, the patient has to pee it out, right? The patient has to pee it out. So chronic cystitis looks similar to interstitial cystitis. However, with chronic cystitis, when you do your lab, you realize that the urine is abnormal. The urine test is abnormal. So, clues to never forget about overflow incontinence. Look for that patient with a full bladder, continuous dribbling, and long-standing obstructive symptoms. So look for an elderly man. And we learned today that the commonest cause of bladder outlet obstruction is benign prostatic hyperplasia in men as they age. So a patient with a full bladder, continuous dribbling, and long-standing obstructive symptoms has benign prostatic hyperplasia until proven otherwise. Right? For example, you know, the way I always tell the MedCognito candidates that an elderly patient with anemia has colorectal cancer until proven otherwise. So your next best step in an elderly patient with anemia is for you to get colonoscopy. After you get your colonoscopy and colonoscopy is normal, then you start evaluating for other causes. That's how you think in your board exam. Okay, good. So what's my take-home point? My take-home point is this, and by the way, we are going to solve some questions. My take-home point is this. A full bladder that leaks continuously in an elderly man is overflow incontinence until proven otherwise. I hope today I've drilled this into your mind. So when you are sleeping and you get a question like this, you know that Dr. Bruni taught it. A full bladder that leaks continuously in an elderly man is overflow incontinence until proven otherwise. So now let's apply all the knowledge we've gained in some few questions. So this one should be easy for you. And I'm going to time you, okay? So you have a 54-year-old woman who presents with a 9-month history of urinary urgency. Urinary urgency, frequency, and suprapubic pain. The pain worsens as her bladder fails and improves immediately after voiding. She wakes multiple times at night to urinate. Urinalysis and urine culture are repeatedly normal. Cystoscopy shows glomerulations. What's the most likely diagnosis? A, chronic cystitis. B, neurogenic bladder. C, interstitial cystitis. D, overflow incontinence. And E, stress incontinence. So with all that we've learned today, now we are putting everything together. So please remember, in chronic cystitis, there'll be abnormal urine tests. In interstitial cystitis, the urine test is normal. So let me go through the answers again. Dr. Maham Munir, please check it again. Read the question again. Dr. Ruth Ann, please check the question again. There's something I put in there which separates A, chronic cystitis, from C, interstitial cystitis, right? Because what makes it more likely, the correct answer is C, interstitial cystitis. Why did I say so? There's bladder pain which is relieved by voiding, and the urine is normal. The urine is normal. Doctor, so you see, just those two words change the whole game for you. So pain is a defining feature in interstitial cystitis, and it is not present in overflow obstruction. So that's our first question. Let's go to the next one. You have a 62-year-old man with long-standing diabetes who presents with urine retention alternating with episodes of incontinence. Now, he reports poor bladder sensation and difficulty initiating urination. Post-void residual volume is markedly elevated. Neurologic exam shows decreased vibration sense in the feet. What's the most likely diagnosis? A, overflow incontinence due to benign prostatic hyperplasia. B, neurogenic bladder. C, chronic cystitis. D, prostate cancer. And E, urge incontinence. Now you see the way a trained doctor for the QE1 is answering the questions. Everyone is going for B, 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 B. That tells me that my work here is done. I've done my work and I'm so happy. Everyone is going for B. Why? Because the patient has diabetes. He's developed diabetic neuropathy, right? And that is why it is affecting the legs. In the feet, they will have pins and needles. And now it has become so bad that it affects his bladder. Doctors, we got this right. Everybody got it right. I have a question before we continue. How has the class been so far? How has the class been so far, doctors? Tell me. How has the class been so far? Let me know. How has the class been so far? You see, this exam, you have to just learn how to break things down. When you break things down, now when you are presented with any question, it's easy, right? So Dr. Ezekiel says, awesome. Dr. Waka says, awesome, brilliant. Good. That is it. If you're able to break things down, the exam is not difficult anymore. Let's go to the next question. So neurogenic bladder. Why is it neurogenic bladder? And why were you able to just pick it up that this is a neurogenic bladder? There's impaired bladder sensation. It is not just obstruction. This is the TRUSA underactivity because of the neuropathy, the diabetic neuropathy. Okay, good. Next question. A 48-year-old woman presents with dysuria, urinary urgency, and frequency for several weeks. Look at it very well. Several weeks. Now she reports suprapubic discomfort, but no relief after voiding. So this is where you should be able to separate those two. By the way, when I say those two, which two diagnoses am I talking about? Doctors, listen to this. The patient has been having the dysuria, urgency, frequency for several weeks. Now she reports suprapubic discomfort, but no relief after voiding. I'm going to stop reading the question. Which two diagnoses are you being tested on right now? Which two diagnoses? Both of them will present with urgency, frequency of urination, dysuria. And both of them would have been there for a long time. But then, one of them is relieved when the patient pees. The other one is not relieved when the patient pees. What a beautiful, beautiful, beautiful. Chronic cystitis and interstitial cystitis. Chronic cystitis and interstitial cystitis. So doctors, if interstitial cystitis was something difficult for you, today it's been made ridiculously simple. So, urinalysis, however, shows pyuria and bacteriuria. Symptoms partially improve with antibiotics, but recur shortly after completion. What's the most likely diagnosis? A, interstitial cystitis. B, chronic cystitis. C, neurogenic bladder. D, overflow incontinence. And E, bladder cancer. What's the correct answer? Please tell me the correct answer. Tell me the correct answer. You can't come to this class and miss this. You can't come to this class and miss this. And everybody is going for B, chronic cystitis. Good. So infection markers are present in chronic cystitis. There's pyuria, there's bacteriuria, and interstitial cystitis has negative urine culture. Okay. I'm so excited. And then this doctor says, the recurrence of symptoms shortly after antibiotic therapy gave it away. There we go. Next question. A 69-year-old man presents for routine follow-up. He denies urinary frequency, urgency, and or incontinence. Digital rectal exam reveals a hard, irregular prostate. Prostate-specific antigen is elevated. Post-void residual volume is normal. What's the most likely diagnosis? A, benign prostatic hyperplasia. B, overflow incontinence. C, neurogenic bladder. D, prostate cancer. And E, chronic cystitis. What's the correct answer? What is the correct answer? Tell me. What is the correct answer? This one is simple. What's the correct answer? The correct answer is D, prostate cancer. How will you be able to tell prostate cancer on physical exam? Remember, as part of the whole thing, the medical council, let me bring this thing to you again. The medical council wants you to be able to use physical exam. Where is it? An appropriate history and physical exam to be able to tell BPH, benign prostatic hyperplasia, from prostate cancer. Okay, so let's go back. Prostate cancer. What are the features? There's hard, irregular prostate, normal voiding early. Prostate cancer is often silent until it's advanced. Next question. 75-year-old man presents with nocturia, weak urinary stream, hesitancy, and sensation of incomplete bladder emptying. Over the past month, he's developed continuous dribbling incontinence. He denies dysuria or suprapubic pain. Post-void residual volume is 450 mils. What's the most likely diagnosis? A, interstitial cystitis. This is very easy. B, chronic cystitis. C, urge incontinence. D, neurogenic bladder. And E, overflow incontinence. Doctors, what's the correct answer? Tell me. What's the correct answer? Correct answer A. What's the correct answer? Correct answer A. What's the correct answer? And this looks like the first question which started this whole game. Overflow incontinence. There's obstructive symptoms, high post-void residual urine, continuous dribbling. Classic progression from outlet obstruction to overflow obstruction. And if you got E, you need a thumbs up from Dr. Brony. If you chose E. Okay? So doctors, we are done with everything. So I'm going to do my active recall and then we'll bring the class to an end. However, I want you to know, those who are also preparing for NAC OSCE, you have the opportunity to take advantage of our early bird registration. Okay? Our early bird registration. I'm going to just share the screen with you. For those, please don't forget, we're about to do our active recall. But I just want you to know, 217 lessons. There'll be 17 sections. You'll get an introduction and onboarding. Okay? You will get communication like a pro, and you realize that we are changing our website, right? We are changing everything. You're going to get communication like a pro, 13 lessons there on how to communicate effectively in NAC OSCE. And then obstetrics and gynecology, you're going to get 18 lessons. NAC OSCE psychiatry, you're going to get 8 lessons. Gastroenterology, you're going to get at least 6 lessons. Musculoskeletal, 19 lessons. Respirology and cardiology, 22 lessons in there. Neurology, 10 lessons. Endocrinology, 6 lessons, right? Counseling, 10 lessons. Pediatrics, 16. So on and on and on. And you can do a one-time payment of just 1,997 Canadian dollars. Now, if you also want to pay over 2 months, it's just $1,050 for 2 months. And you get access till your exam. Classes will start on January 6th. So I'm just letting you know, we are running a promo for NAC OSCE. So if you are interested, this is the time. And I'm also going to share the link in the comment section right away. Okay? And if you also have friends who want to register for NAC OSCE as well, you can tell them. By the way, if you refer a friend who takes the Nakoski course with us, or even our QE1 course with us, you get 10% discount, right? So if you want to take the Nakoski course for free, all you need to do is to send 10 friends our way who will all register, and you get access for it for free. If you send one friend who registers for the $1,997, you'll be sent $197 back free. So the number of referrals you send and they register, you get that in your bank account free. So I'm just letting you know. So if you want to take our course, Nakoski, for free, just refer 10 friends. Let's make sure they all register. They are all in the program, and you get it for free. Okay, so now let's go back. Let's log in. And by the way, our Q1 as well, it's only 2,200 Canadian dollars. Just 2,200 Canadian dollars for a one-time payment. If you also want to make it month by month, it's only $420 every month. Okay, and then you have access to the whole thing. And if you want to reach me right away after the class, text me on +1 306 891 5649 +1 306 891 5649. Now let's look into the concepts. Now you have a patient who has pain in the bladder, and this pain is relieved by voiding. What's your diagnosis? So with all the English the medical council will write, if you see this, pain relieved by voiding, what's the correct answer? What's your answer based on what we've studied today? Based on what we've studied today, pain which is relieved by voiding, what is your answer? Tell me. Tell me. Look at that. Look at that. Look at that. Let's have it. 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 Good. The answer is interstitial cystitis. Boom. Simple. Okay. Interstitial cystitis. I'm waiting for everybody to bring their answers. Then we go to the next question. Urine incontinence plus neurologic disease plus poor sensation. Urine incontinence plus neurologic disease plus poor sensation. Let's have it. Let's have it. Let's have it. Let's go. Let's go. Type your answers. Let's go. Type your answers. Let's go. Type your answers. Let's go. Urine incontinence plus neurologic disease plus poor sensation. Let's go. Let's go. Let's go. Let's go. Neurogenic bladder. Neurogenic bladder. Neurogenic bladder. Doctors, you see, if you are taught properly, these concepts are not difficult. Next question. Let's have it. Pyuria or bacteriuria, which seems not to improve with antibiotics for months. What's your diagnosis? Let's have it. 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 Let's go. Let's go. Let's go. What's your correct answer? Chronic cystitis. Don't just type cystitis. Chronic cystitis. Chronic cystitis, right? Next one. Hard prostate. Earlier asymptomatic in a 76-year-old male with maybe the patient is peeing lots and now feels that the bladder is always full. What's your diagnosis? By the way, doctors, please, if you're on this live stream, please make sure that you've clicked on the like and subscribe button. Click on the like and subscribe button on MedCognito YouTube. Please do that right now. Do that right now. Like and subscribe our YouTube channel. Like and subscribe our YouTube channel. Like and subscribe our YouTube channel so that we can grow it. So this patient has prostate cancer. And then what about elderly man, full bladder, dribbling, high residual volume of urine? And you do your prostate exam. It's soft. It doesn't have the features of prostate cancer. What is your answer? What then becomes your answer? Full bladder, dribbling, high residual volume. So overflow incontinence as a result of benign prostatic hyperplasia. Okay? So doctors, that's my phone number. I know after this class, my phone number is going to get very busy. +1 306 891 5649. +1 306 891 5649. So if you want to belong to our inner circle, right, of those who meet with us, and people bring up their concerns in the group, and we're able to, like, people, as they solve various question banks and the rest, they don't understand something, we're also there for them. You're going to get, a question bank as well to study with. You're going to get what you call med bullets. Med bullets is like, the final revision. We've already done that in video format for you. Okay, you're going to get mocks every 2 weeks at a discount. You're going to get mocks you can do at home on your own. And then you're going to get live lectures, which will also be recorded. Ladies and gentlemen, doctors of the noble profession, this is my phone number. And as usual, it's your friend. It's your brother. It's your guide in this journey who wants to see all of us succeed. This is Dr. Bruni. And it was a pleasure to spend our afternoon together. So if you want to reach me right away after this class, this is my phone number. I will respond myself. +1 306 891 5649. Thank you very much, doctors. Thank you. Let's get the game going. It was a pleasure. All the best. Bye-bye.